nerve sensation for the lower lip and the chin, and the incisive nerve innervate the lower teeth. It's very important to remember this picture because actually this is the branches that emerge the mandibular nerve and give sensation to the teeth. Why this is important? Because during the nerve transposition, when I want to extract the nerve from the canal, to take it out from the canal, usually I can meet these branches and I have to separate them. It can make the surgery a little bit difficult, but if we know that this small branch is still there, we can deal with this. So the history is not so far, but at the first time, a line was described the nerve transposition to treat the patients for dentures, because when the nerve is so superficial, the denture can be uncomfortable for the patient, and he just did a nerve transposition to make the denture more comfortable. For dental implants, it was began at 1987 and 1992. A little bit cases was reported. Later on, I think that the nerve transposition was neglected because of the neurosensory complications. But actually, if we look at the literature at the last decade, there is an increasing global trend in the treatment involving the nerve transposition, because this operation can give the patient's teeth. It may be the only option to give him teeth and the first option. And almost all the articles, also from my experience, the patients can tolerate the paresthesia or neurosensory complications, small complications that usually over 3 or to 6 months, all the patients have the regular sensation. But when I ask them to compare themselves before and after the surgery, actually all of them like that they have teeth. So, as I said before, it's at the last decades, I meet at the literature more and more articles that speak about the success rate of the implants with nerve transposition and the complications. That actually, we can say small complications. The candidates is actually a severe atrophy of the mandible. We can see the Code and Howell classification. We deal with the class 4, 5, and 6. In class 4, 5, and 6, there is no, the bone augmentation is extremely difficult. We cannot make osteodestruction, osteogenesis. We cannot insert short implants. So the only way to treat the patients is with the nerve transposition. When we look at the CBCT of the patient, we have to look for the height of the bone and the width of the bone, and of course the angulation of the bone. But when we have short implants, actually need the minimum of 7 millimeters above the nerve and bone width more than 6 millimeters. If we have less than 6 millimeters above the nerve, we cannot use usually short implants. When we have a bone height more than 10 millimeters and width more than 6 millimeters, it's the dream for all the patients and for all the surgeons that make implants to have this more than 10 millimeters, so we can use the usual implants. If we ignore the nerve, this is the nerve, and if we ignore the nerve, we can see that we have a lot of bone. We have a very beautiful height of bone. This is the mandibular height, okay? And this is the available bone above the nerve, about 2-3 millimeters. Of course, here can do nothing without bone augmentation, major bone augmentation. But if we look at the mandibular height, I can insert here very nice long implant with bicortical anchorage. This is excellent for nerve transposition. Okay, we can see here at the CBCT slice that we can put here very nice implant if we ignore the nerve or if we take the nerve out. I actually talk about the important factor during the treatment planning for nerve transposition at this time, because this is the topic. So, and I can see here that I can have a very nice mandibular height. Here the intermaxillary distance is not, if I make here bone augmentation in order to insert implant, there will not be a room to make teeth. So when the intermaxillary space is reduced, the best way is to make nerve transposition. Okay. Sometimes we have a problem with the nerve transposition, like when we have a small width of the bone or a big angulation of the jaw. I cannot insert the implant like that. I have to make bone augmentation, and sometimes I have to make after the bone augmentation nerve transposition in some cases. But at this angulation and at this width, I have to make bone augmentation. The quality of bone, if we look at D1 and D4, when I want to access the nerve, it will be very difficult to do it at this bone quality. We do it, but it will be, I will know that I will have work hard to reach the nerve. Here, once I go inside the cortical bone, the cancellous bone will be very easy to take out and to reach the nerve. So the quality of bone, it's very important when I look at the CBCT for the patient when I planning nerve transposition. Of course, the cortical bone width also tell me if I will have a hard job or easy job, like a sinus floor elevation when I make the window at the buccal wall of the sinus. When I have a thick wall, I will reach the sinus, but I will have to work hard. The same at this surgery. If I look at the position of the nerve inside the mandible, when the nerve is close to the buccal plate, the surgery will be easy. When it's more deeper, the surgery will be more difficult. We can do it, but I will know that it will be more difficult. And important topic here that in this case I can insert guided implant insertion. I don't need to make a nerve transposition. We will see cases later, but the location of the nerve, it's very important to know which kind of surgery I will have. When I have buccally or lingually from the mandibular canal more than 5 millimeters, I have good solution for the patient. I can make a guided implant insertion. We can see here the two implants at the buccal side. Here's the buccal. This is the mental foramen. So it's the buccal side. We can insert two very nice long implants without the need of nerve transposition. As we see here, okay, this is the buccally located nerve, and this is lingually located nerve. In the both cases, I can make a guided implant insertion very easily, very fastly, and there is no need for a nerve transposition. When I have to look also at the level of the mandibular ridge. I see here that the mandibular ridge is the crest is very straight. So if I cannot insert here implants without bone augmentation. But if I make here bone augmentation, I will have an even, this side will be higher than this side. So in those cases, I prefer to make a nerve transposition. especially when I have good mandibular height. You can see here, it's very nice. If we compare the right side where I make nerve transposition, I can insert longer implants to the previous surgery that the patient have somewhere. The implants are short and they didn't have enough bone. I have to look at the vertical location of the nerve inside or outside. Sometimes the course of the nerve, because of the severe atrophy, becoming so superficial. So in these situations, I have to take care when I make my first cut at the soft tissue, because I can cut the nerve. Of course, in those cases, I think we have to make some kind of bone augmentation with nerve transposition, because I have to reposition the nerve not under the soft tissue. I have to protect the nerve with bone. We will see later. Of course, when we have atrophy of the bone, usually it combined with the atrophy of the soft tissue. You can see here the atrophy of the alveolar ridge and the thin type soft tissue. I can close maybe I can close my flap, but when I make the rehabilitation, I didn't have enough soft tissue. So we will keep this in mind, that when we make bone augmentation or nerve transposition, we have to improve the soft tissue quality. The second problem with when we have severe atrophy, we will see that the cheek, the ridge, and the floor of the mouth at the same level. So if I use here short implants, the cheek will be more above the edge of the crown, and also the linguals at the lingual side, the edge of the crown will be under the floor of the mouth, and it's very difficult to clean. And all the time the patient will have some kind of gingivitis or periimplantitis. So in those cases, I have to keep in my mind that I have to improve the soft tissue thickness and height. Actually, the big problem, or the big opportunity to the patients, that some patients have intact interforamen teeth. If I decide to make all in four, I have to sacrifice all the teeth, all the good teeth. So at this scenario, the indication for nerve transposition is the optimal treatment for the patients, because I have to keep those teeth, okay? The anterior teeth here and here, and I make here nerve transposition bilaterally. I keep the teeth, and again I meet some patients that went to another clinics, and they make them all on 4 or on 6, but they had to sacrifice the anterior teeth. When we talk about the surgery, we have two kinds of nerve transposition, reposition. We have the lateralization and transposition, and there is a new approach that I take the nerve to the superior, when I have the nerve at the superior part of the ridge, I call this superiorization, and you will see some cases with this topic. So actually, lateralization, we didn't touch the mental foramen. The mental foramen is still intact. We make the surgery distal to the mental foramen, and we take the nerve out. We have to hold it far from the implant insertions, and this is very nice with less complications. But the elasticity of the nerve is so difficult to pull all the time, and you have to watch your assistant and to watch the suction all the time. So a lot of, actually, a lot of surgeons make the nerve transposition only, lateralization only. The transposition of the nerve, it's include the osteotomy of the mental foramen, and we take out all the nerve with the mental foramen, and actually the nerve is lying outside the jaw during the surgery. Also, again, you have to watch your assistant not to pull so much, or not to make suction over the nerve all the time. We make the nerve transposition when the nerve is at the lingual side. If we imagine that the nerve at the lingual side, so we have to at this side, when I take the nerve out, I should have enough length here of the nerve exposed to take it from the lingual to the buccal side. Okay, so usually we go distally, more distally. And it's very important actually when we have to put implant at the molar foramen area. So in this case also we make nerve transposition, not lateralization. We can see here the different. This is the mental foramen when I make osteotomy of the mental foramen. This is the incisive. I cut it anterior to the about 5 millimeters anterior to the nerve, to the foramen nerve. I take out all the nerve outside. At this picture, it's not very nice, but you can see that you can't see actually, but the mental foramen is here at this place. Actually, when we meet patient and I want to make nerve transposition, I have to choose my patients carefully. I have to ensure that the patient understand the surgery and understand the paresthesia. Almost all the patients after the surgery will have 2 to several weeks of paresthesia, and we have to be sure that they understand the sensation. So every patient that I want to make him this surgery, I make 2 mental blocks or one mental block. If it's bilateral, I give him 2 mental blocks, and I told him you will feel like that several weeks. It's only sensation. If I look at you, I will never know that your lip or your chin is have numbness, but you know, because it's not movement. You can eat, you can kiss, you can do whatever you want because it's not motor sensation. It's a sensory sensation. So all the patients should have this block before the surgery, and at the first meeting time when we deal with this surgery. Okay, how we make, there is a lot of surgical approaches at the literature. Some of the surgeons remove all the buccal plate. I prefer to move a little bit buccal window as the pathway of the nerve, and you see here the osteotomy of the buccal window, the osteotomy of the mental foramen, and this is the beginning. I can see here the mental foramen. I have to make osteotomy around it because it's canal, and the nerve is somewhere here. I can see it with the CBCT slices. Later on, we began to make a surgical guide to know exactly where is the course of the course of the nerve. This is the incisive nerve somewhere here. I have to cut it here in order to make lateral transposition of the nerve. And this is the once I release the incisive nerve, you can see here the cutting of the nerve, and take out the nerve from the mental foramen. I began my surgery slowly. Actually, nowadays I working over a special kit instruments to make the job easier. So soon I will have my own transposition nerve transposition kit. And of course we hold. You can see here. I will talk about this later. I protect the nerve with this tube. and I take the nerve from the stretching and from the suction, and I insert my implants. You can see here the implants inside. This is the osteotomy window. This is the nerve outside the canal. We can see here that actually the mental foramen that once was here, the nerve exit the jaw at this point, and this is called the molar foramen. Usually I fill the in between the nerve and the implants. I put allograft, and when I reposition the nerve, again I put allograft over the nerve. I use allograft for certain reason. I will talk about later. And this is a membrane and a closure of the. Maybe we have 2 minutes of video how it looks at the real time. We will soon see the CBCT of the patient with the superficial location of the nerve. Here I cannot make short implants. This is intraoral views, severe atrophy of the soft tissue. The first cut will be so careful not to hurt the nerve with my scalpel. The releasing of the soft tissue. This is the mental foramen. And during the surgery, at first I mark my implant place where I want to insert the implant, usually with high speed. And I began my work with the mental foramen osteotomy. We can use a small round bar. I prefer to use the piezo because it's give me more good results regarding the sensory problems. And here you can see the cutting with the piezo surgery. Usually I make as less as I can. I want to make a small window. I use the osteotome to release the buccal window. We here began to walk over the nerve. We can see the nerve. This is the nerve here. I continue I usually use this. I take out the first window in order to know the pathway of the nerve inside the jaw. I can use also microsaw. You can see here the walking over the nerve. The most difficult area around the mental foramen, because we have a lot of bone, the bone canal of the mental foramen. It's difficult to take out. I began slowly to release my nerve from the inside the bone, and again you can see I proceed from the anterior to the posterior side, the implant preparation, implant place preparation. You can see I use a lot of water because the bone is I think poor quality. Maybe it's D1 or D2. We have to use a lot of bone. I hold the nerve here. You see, I hold the nerve. I drill with protection beside the nerve, because I usually prefer that my assistant. I prefer to make the protection by myself. This is the implant insertion. It's a hard bone. You can see that it's a hard bone. I have to look if I didn't have here microfractures at the bone. So I make it slowly in and out sometimes. This is the implant, this is the nerve inside the canal. I usually use the buccal fat graft to protect the operation and to augment the soft tissue. It's very easy to take it to harvest the fat tissue. This is free fat tissue graft. Closing the screw, the implants with screws, inserting of allograft between the implants and the nerve. It's a sticky bone. And I cover all the operation with allograft. I didn't use xenograft for some reason. I will talk later about this reason. The fat tissue over the entire surgical site. The fixation of the fat tissue is very important, and I continue suturing to reach primary tension-free but double layered. The fat tissue is used to protect the augmentation and the implants and to augment the soft tissue at the same surgery. So this is the final closure. The right side, the same operation, so I will skip this side, sorry, and we will continue with the lecture. I will show you some cases with the nerve transposition. Actually, when I make nerve transposition, I know that I put the implant in the natural bone of the patient, and I have bicortical anchorage of the implant. These patients may, I cannot make here short implants because the bone is not good for short implant. I have here about 4 or 5 millimeters, and here we have a deficit at the horizontal plane. And the fast treatment for this patients, when I discuss the options with her, she chose the nerve transposition because she can have a rehabilitation at the same day, temporary rehabilitation, and the final rehabilitation will be after 3 months. If I make here bone augmentation, maybe I will have some problems with the upper jaw, but actually I have to wait 4 to 6 months after the bone augmentation, and then I will have to insert implants and wait again for 3 or 4 months. So when I make nerve transposition, I know that the implant is inserted at the natural bone of the patient. I will have a long implant to insert. So we choose this option. You can see here during the surgery, I inserted 3 implants. Usually I use the buccal fat pad with this kind of operation because usually have atrophy of the soft tissues. We can see here the 3 nice long implants. I think it's 16 millimeters, and this is 13 millimeters. We have very nice implants. I make the surgery in one stage, the nerve transposition and the implant insertions, so the patient can have a final rehabilitation very quick. I usually use the healing caps at the same day. This is the healing. We can see the very nice location of implants, and we can see here the very nice soft tissue. This thick soft tissue, I get it because I use the fat tissue. Okay, we will talk about this later maybe. And this is the follow-up. We can see the very nice rehabilitation. And the patient, 36 months after the surgery, she make a CT to insert implants at the right side, and so we can see the very nice implants. And this is here we can see the moral foramen here. And in some cases we can see that a new canal was regenerated here at this area. Usually, I prefer not to have male patients because they have to shave after surgery. They have to shave their face, so I am afraid from the neurosensory, from the paresthesia. But actually, they can do it without hurting their skin. So I have here a female 63 years that he want to have implants and fast. And if we look at the quality of the bone, it's very poor. It's D1, it's a hard, it's a marble bone. And if we make bone augmentation, it will be the predictability of the success is not so well. And the patient was not interested to make bone augmentation. He want to make it fast. I know when I look at the CT again, I will know that I will have a hard work to reach the nerve, but we can do it. And he had 8 implants. Okay. Again, we have here. Actually, in my clinic or at the department, when I see a situation that it could be treated by nerve transfusion, I have to tell the patient about this option all the time. He will choose, and we will choose together the best the fast and maybe the less cost option. So I actually all the time when I have a small amount of bone over the nerve, I suggest the patient to make one of the options is nerve transposition. This patient had failed implants and at the left side, and we decided to make the nerve transposition. This is the intraoperative view. We can see the small bone window and the nerve outside. The implants, we insert 3 implants here. And this is the closure with the allograft and membrane, of course, with fat tissue. And this is the implants after the follow-up. We can see the nice healing of the surgery and the rehabilitation over the implants. After 3 months, she had a fixed prosthesis over the implants. The results is very nice, and the patient was so happy to finish the job very fastly. Actually, if we talk about indications, when we have atrophic ridge with intermaxillary space, so we will not have enough room to make vertical bone augmentation. When we have enough mandibular height, we prefer to make nerve transposition. When we have severe atrophy with enlarged intermaxillary space, sometimes we make bone augmentation, and sometimes even we make bone augmentation, we still have to make after the augmentation or short implants or make nerve transposition to insert long implants. At extremely atrophic mandible, I maybe talk about 4 or 5 millimeters or 6 millimeters of the total mandibular height. The only option is to make only bone block and to take the nerve out and to put implants. Of course, we receive a lot of patients. They had multiple bone augmentation surgeries at the past, and the surgeons or the doctors referred them to our department or to me to make nerve transposition. And again, we have to remember here that when we have good interforamen teeth in good situation, it's an important indication for nerve transposition, because usually I keep those teeth. I didn't make all on 4 or all on 6 because I will lose 6 or 8 good teeth. So what's good with the nerve transposition? We can use the standard long implants with bicortical anchorage, because I use the lower border of the mandible to insert the implant. I will have very nice primary stability. I can make temporary restoration over the implant. And of course, when I have by cortical encourage the occlusal resistance to the occlusal forces will be good for the implants and the long-term success of the implant. When we make this surgery and we can make the implant at the same time, and when we compare short implants with nerve transposition, in our experience, we can see that we saw that the long implants with the nerve transposition survive more time than short implants. Okay. So again, what I like with this surgery, always sometimes the only option for the patient to have fixed prosthesis with over the implants, the entire dentulous mandible or the posterior dentulous mandible. We can make immediate loading of those implants because they have a bicortical anchorage, and fixed prosthesis. Doctors can make it after only 3 months. Again, the success rate of this kind of surgeries is that there is no risk for to lose the bone when I augment the bone, because I use the patient natural bone. It's a fantastic way to treat posterior atrophic ridges. The complications, usually I put here mandibular fracture first, but actually the neurosensory sensory disturbance or the temporal paresthesia or more prolonged paresthesia, and sometimes hyperesthesia. It's more difficult to the patients to have hyperesthesia. Hyperesthesia, when the patient touches his lip or his chin, it will cause him allodynia. It's not very nice kind of pain. But usually the hyperesthesia or allodynia is rare with this kind of operations, because actually we see the nerve and we keep it. And it's more difficult when we see at the department, actually at I can say at the daily practice, patients with implants that was inserted inside the canal or too close to the canal, or that the drilling was inside the canal, and when the doctor saw that he's something with the bleeding, he inserted a smaller implant, but the paresthesia is still there. So it's better to see the nerve in order to insert more beautiful and longer implants. The rare complications actually can happen with atrophy of the mandible. If we make 4 implants at the anterior mandible, when we have severe atrophy, the mandible also may be fractured. So in my career, I have 2 mandibular fractures after nerve transpositions, and usually it occurs 4 weeks after the surgery. So it's very important when we make this hard wisdom teeth extraction, when you remove a lot of bone, or when you make implants at the severe atrophic anterior mandible, or if you make nerve transposition, I always inform my patient, you have to eat. I love with them, you have to drink soft tissue, not to eat. Soft diet, not to eat. You have to have soft tissue that you drink it, not eat it. Okay? Because after 4 weeks, the bone is undergoing the maximum, the peak of the remodeling, and the bone will be very weak after 1 month. So we will have to keep this in mind even when we make a difficult wisdom teeth extraction. It can be after the fraction can be spontaneous. Throughout my experience, I have a classification for the nerve transposition. I have several clinical innovation in this topic, and when I look at the patient, I can put him at specific category, so I can explain him what he will underwent with this surgery, how long, how much it will cost. So the patient was divided in 4 categories. I look actually in my classification. I look at the mandibular height, the total mandibular height, the nerve location, and how much bone I have above the nerve. Okay, we saw it before. The mandibular height. If I have bone height from 0 to 7 millimeters, I cannot insert short implants. Of course, I cannot make destruction osteogenesis. I can make specific patient implant like subperiosteal implant, but here I always like to make nerve transposition because I want to insert long implants. I have problem when I have this kind of bone, when I have not enough width, or the width and the height is not enough. So I have to make here something before the nerve transposition or during the nerve transposition. I mean bone, some kind of bone augmentation. The location of the nerve is very important. Again, we will see why. The category 1, I called it good mandibular ridge dimensions. I have here a very nice length and a very nice width. The nerve somewhere here, I cannot make short implants. I cannot make a guided implant insertion. So I can have here a very nice long implant. And usually it's done at the same surgery. What I said before, at this category, when I have good dimensions, I insert the implant at the same day. And it's very important to listen to what I want to say here. When the bone height over the nerve above 3 millimeters, I access the nerve from the buccal. I make buccal window. As we saw in the movie, the access to the nerve is from the buccal window. But when I have the nerve in so superficial location, I access the nerve from the superior part of the crest. So this is a illustration. Young lady, I think it was 40. No, this is the lady with the. She was. We saw before this case, so I go over it. This is a lady with 49 years old. I remember she had a very nice bone here. You can see 10 millimeters more and more. If I want to implants, I can reach this area. The bone width was more than 4 millimeters, so I can insert very nice implant. She had at the past 10 implants here. She lost all of them, and she was referred for me to make her nerve transposition. This is during the surgery. I make the implants, the nerve transposition, and this is the X-ray after the surgery. Here, you can see her once the nerve was here, okay? And she had a very nice rehabilitation, and she was so happy, and work was completed during less than 5 months. Category 2, when I didn't have enough bone dimensions, I talk about the mandibular height was more than 6 millimeters, but less than 10 millimeters. The width was less than 6 millimeters. The bone was so angulated. You remember the angulation, and the bone over the nerve was 3 to 6 millimeters, so I cannot insert a short implant. At this situation, we make surgeries. At the first surgery, we make bone augmentation. You can see here, even when I make bone augmentation, I didn't improve the height a little bit, the height of the bone, because also I want to keep the level of the crest here. So this patient was informed before the surgery that she will have, the second surgery will be nerve transposition. We can see here the nerve transposition and the insertion of the implant. At this side, I make a bone augmentation only and shorter implants. I think it's 8, this is 10, and this is 8. And what is very nice with the nerve transposition, when I reposition the nerve partially inside the bone, we can see the new canal bone generation. The nerve can build his own new canal. When I have moderate dimensions, we will see pictures will be easier to explain. We can make one surgery, we can make a nerve transposition and the bone augmentation on the same day. We can use bone blocks, or we can use a GBR with the membrane. So you can see here, I have some problem to insert because if I make nerve transposition, the implant will be here at this area without bone, or I have to reduce this bone, or it's better to augment this area. So I use a bone block from the retromolar area here. Sometimes the atrophy is so difficult, so I didn't have this bone. But in this case, I have this bone, so I use the bone block from the retromolar area to augment the bone and to make nerve transposition. I can fix my implants with the implants. I have to make it very carefully because I didn't want to fracture this bone block. So I make the drills before I make very nice drills, and I insert at the same surgery. I insert the implants and augment the bone. Sometimes, as I said before, I make nerve transposition. I have a little bit problems, the exposure of the implants here, so I have to protect the implants. I make the GBR. I put here a bone covered with membrane. Usually I use we cannot see here the screws for the membrane fixation, but it's also a kind of bone augmentation at the same day of the surgery, and this is the category 3. What common between the category 1 to 3, that the access to the nerve it's made via the buccal window, because I have enough. It's enough for me more than 3 millimeters to access the nerve from the buccal side, as we see here. We take the nerve out, the mandible, and it's very important, when I finish my surgery, I have where to put the nerve back inside the bone, because I have here bone. I have here the osteotomy and the buccal window, so I insert the nerve inside the bone, and we will soon understand what I'm speaking about, what the difference. Again, when I look at the healing of the, we can see here the nerve, but actually if we look, we can see that the nerve built a new canal. The nerve had the capacity to rebuild a new canal and to protect itself. You can see that one day the nerve was here, and after I take it out and put it back after the implant, he can heal. He can make a new bone canal. So this is the idea for the next category. I have extreme atrophy of the ridge. I think all of you met some kind of patients, and some days he had here implants, they all failed. And I call this category Coward and Howell class 6. Sometimes it's called class 7 because the nerve is outside the jaw. So what here I didn't have enough mandibular height, you can see. And the second problem, the access to the nerve should be from the superior part, because I want to sacrifice small bone, and to reach here, I will finish all the mandibular height. So the access to the nerve is from the upper side. And when I put the nerve back, I will insert here implant. The nerve is here, and when I put it back, it will have no bone over it. So it's the idea of this category, how to improve the height of the bone, how to take the nerve out, and how to protect the nerve to be inside the bone. This is happening when I have mandibular height less than 8 millimeters, less than 6 millimeters. The location of the nerve, the mandibular and also the mental nerve, is at the superficial part of the crest, and sometimes outside the crest. In this group, the surgery is completed in one surgery. Examples, we can see here the location of the nerve. This patient cannot use even, there's not enough bone to put implants when look at the CT, but she was interested to make a fixed prosthesis. The nerve is outside the jaw, we can see here. You can see here also. And this is, we have here good interforaminal teeth. So here we have to make something to give the patient teeth. And this group of patients, actually, they are extremely sad. They didn't have a quality of life, because they usually use denture, partial or full denture, and they cannot use it. When they eat, they will have the pain from the pressure over the nerve or over the mental nerve. They have difficulties to eat and to speak. They cannot, some of them avoid social events, and they usually have different degrees of neuralgia from the pressure of the denture. So what we can do for these patients? So the access to the nerve, okay, this is the idea. Actually, the access to the nerve is to the upper side. It's called superiorization. I access the nerve from the upper crest. I have to make bone augmentation here. Okay, I insert the implant through the bone block and the basal bone of the patient, and at the end of the day, I will know that I will have where to reposition the nerve. This bone will protect the nerve. This bone will be the roof of the new roof of the nerve, and it will protect the nerve from the outside intraoral stimulation, I call it. This is the idea of and it's called superiorization of the nerve and roofing of the nerve. I have a clinical innovation before, I think, 3, 4, 5 years at the Academy of Osseointegration, and I have a article. You can look at the PubMed. You can see the article about the superiorization of the inferior nerve and the roofing. The donor side is the calvaria. Why I use calvaria? Because usually those cases I didn't have enough bone inside the mouth, so I have to choose outside the donor side. I like the calvaria because long standing of this bone. If I use the iliac crest, I have more bone there, but it's all of us that deal with the major bone augmentation know very well that the iliac crest will not survive for a long time. This bone will survive a long time, and we can see the small movie that how can I do it. It's actually not a hard surgery, and the surgical side is very accessible. Usually patient didn't like this area, but this is the preferred option. And Olivia complication is not the case, but we can see the severe atrophy of the postmandible jaws. You can see knife edge. I access at the parietal bone, small incision to expose the parietal bone of the patient. I use this suture for hemostasis, and here we began the job. I like to use the piezo surgery, but you can use bears also. I prefer to take small blocks because I need small blocks inside the mouth. So I make several osteotomies. I use the low speed to have space to insert the osteotome, my osteotome later on. We make this operation at the operation room of the hospital. You can see here I take out the the bone block. I have to check if I reach the dura of the patient. You can see that it's okay. I can take some cancellous bone, and I continue with my job to take out to harvest the bone blocks. Usually, for nerve transposition, I need less bone blocks, but in this case specifically, I need more. I continue with harvesting the bone blocks, as you see here. Sorry, I think you have you didn't. So this is the bone blocks that I had. The final closure of the donor site, very easy. We have to control bleeding. We use some gel foam sometimes or bone wax. And this is the final closure of the. I like to use this kind of sutures because the healing is very well. Okay. So cases. This is a 55 years old female. She had extremely atrophic both jaws, and she came to the department seeking fixed prosthesis over the implants. So she underwent 2 surgeries. The first surgery was to augment the maxilla. You can see here the thin, like it's extremely thin bone here. We augment the maxilla, the anterior part of the mandible. This is the situation after 4 months, and we can see at the anterior area here, the bone augmentation, and she still have to make here additional bone augmentation and the nerve transposition. This is the surgery. We can see here that we access the nerve from the superior part of the crest because it was so superficial. Here, when we have to take care at the first cut with the scalpel because I can't cut the nerve here. This is the mental nerve, it's just like that at the superior, under or beneath the soft tissue. This is the previous bone augmentation at the anterior side. This is the varia again of the same patient. We can see the healing from the previous harvesting here. And supervision of the nerve, I take it at the upper side. I insert make the drilling for the implants, and I fix the block with the implants. This is, I have here a roof for the nerve. I have where to reinsert the nerve, and it's very good for the nerve because it can have a new canal around it. I usually always I use the fat tissue for two reasons: to augment the soft tissue because the soft tissue is so atrophic, and to close my crazy operation with 2 layers. And the fat tissue will act as a lining, soft lining for the original flap. And it's all the time, it's works very nice. You can see here the bone augmentation, the implants, and the nerve under the new roof, and the fat tissue all the time. I call it the bodyguard of me with this kind of operations. I have a clinical innovation before about 10 years, again at the Academy of Integration at the USA. I have several articles. You can look for those articles. And this is the healing process. We can see the very nice healing. We can see here that this is the nerve, and we can see the new canal of the nerve. This is the new canal of the nerve here. You can see here the new canal of the nerve that is after 12 months, and the very nice bone, thick, and the height of the bone. And this is before. You can see the extremely atrophy of the jaw, the superficial location of the nerve, and the patient had a fixed prosthesis over the implant. She is happy, and the surgery went very well. Again, second case, we have here a poor quality of life of the patient because she has all the time stimulation of the partial denture. Actually, she didn't use it. She had it, but she didn't use it. And so she came to me. It was before, I think, 5 years or more, and she seek for implant placement at the posterior side. She heard about my surgeries in Israel. So we have extreme atrophy. We didn't have enough mandibular height. The nerve is at a superficial location. The idea was to make bone augmentation, insert implant, and fix the bone blocks with the implants, and to reposition the nerve under the new roof, the bone block. And of course, all the time, I use soft tissue graft, and all the time, I prefer the fat tissue. This is intraoperative pictures. Here I need just 2 blocks, so I take only just 2 blocks. And this is the superficial location of the nerve here. This is the superficial axis, and this is the implants. Here it was, I think, between my first cases, so I use screws to make horizontal fixation. Okay, vertical fixation I make with the implants, horizontal I make with the screws, and all the time I use the fat tissue. And this is the healing after 4 months. I extract tissue from the both sides because I didn't make a bilateral augmentation. And this is the follow-up. You can see here the donor site at the calvarial bone. And this is the implants. And this is the follow-up 5 months. And this is the re-entry to expose the implants and to remove the screw. We can see very nice the incorporation of the bone graft inside the jaw. Very nice. And because I use the calvarial bone, I will know that it will survive a long time. This is temporary restoration, and this is the final restoration. This is 18 months after the surgery, and this is 30 months after the surgery. The patient have a excellent quality of life because she had posterior teeth. She also treat her anterior teeth. Another case, extreme case. We have different kinds to augment this bone. Some surgeons use iliac crest to augment the lower border of the mandible. Some patients use reconstruction plate to enhance the strength of the jaw, because this jaw can be broken. So what I know to do is the same surgery. I make the nerve transposition. I take a bone from the calvarian bone, and I insert the implants. I usually fix the implant bone blocks with the implants. I have a very nice roof to protect the nerve. And this is the follow-up. We can see here the bone blocks here. Okay, like I was. You can see here this here. I use usually allograft to fill this. You can see here the bone, but this is a block. Okay. The follow-up was very nice, and patients was so happy. So this is my experience is about 132. It was at the end of 1990. I have a lot of usually I have a lot of bilateral cases. I have 41 patients that they came and they have good mandibular height. I can insert the implant at the same day, and etc. Okay. So we talked about this before, so I will skip this this kind of in order to reduce the complications. When I take the nerve out and I have my assistant, I have to watch them all the time, or her, not to pull the nerve too much. I have to watch the suction over the nerve, because the suction can make dry the nerve, and we can tear some of the fibers of the nerve. So I had an idea that to protect the nerve during the surgery is called nerve tubing. I will have already I will have an article in this topic, and here I insert I cut the tube alongside. I insert it around the implant. So now I can make a suction, and I didn't need any assistant to protect the nerve or to pull the nerve. The second option to reduce the complications is to make a surgical guide to know exactly where is the nerve inside the jaw and how is the depth of the nerve inside the jaw. So we can use usually nowadays use the surgical guide to locate the nerve location and the depth. And actually, the most beautiful thing that I like nowadays is the use of piezo surgery, because I know when I reach the soft tissue, the machine will stop. It will stop cutting. So the piezo surgery can reduce the complications of the sensation after this surgery. So nowadays, we use all these kinds of reducing complications of our patients. Okay. The change in the sensitivity or the sensation, it's anesthesia. It's total absence of any sensation. Usually we have abnormal sensation, and it's spontaneously come after 4 to 10 weeks. I didn't like the allodynia. I didn't like the allodynia and the hyperesthesia, because the patient will be so. We meet this kind of patients when they broken their jaws with road accidents and they cut the nerve. So sometimes they will have total anesthesia, and sometimes they will have allodynia, and when the nerve is repaired, they can have neuralgia. When you touch the area, the patient will cry. So actually, the most of our patients have paresthesia that usually after a few weeks, 10 to 12 weeks, it will maybe I have 3 patients maybe that they have prolonged anesthesia for 1 year, but they get used to this sensation, and they said that some also other literature we can see that many patients didn't complain after 1 year about the paresthesia. How we check the patients? We have several kind of sensory tests. Static light touch, we use a light touch over the area. We can brush the area and ask the patient in which direction I brush. It's very important that we usually use to put 2 points on the chin, and when we ask the patient, does he feel 2 or 1 point? And of course, we can make a mapping of the paresthesia or area. This slide I use here, didn't use usually a needle. I use this stick, and the light touch. I ask the patient to count. I told the patient, every time you feel that I touch your skin, you count 1, 2, 3, 4. So I usually the patient after a few weeks they feel this kind of test, and we can make mapping of the area of the paresthesia, and we usually can follow our patients because this area will be reduced every week after week. We will see that the mapping area is reduced. Of course, we have to check if we have teeth, we have to check the vitality of the teeth, the anterior teeth. This is the patient chart, we called it, and we have to mark the area of altered sensation. It could be paresthesia, it could anesthesia, it could be hyperesthesia. So we use this kind of chart to mapping the neurosensory deficiency of the patient after surgery. If we look at the literature, we see that most of the articles talk about that the neurosensory disturbance will not standing after 6 months. If the sensation have a prolonged time more than 1 year, I usually tell the patient that it will never come back, and we meet it more with the patient with odontogenic tumors or fracture of the jaw. Actually, we know how to correct or how to repair mandibular or lingual nerve. With the surgeries, we use allograft or autograft nerve, but not in this kind of surgeries. So, in conclusion, I deal with this kind of operation about more than 10 years. It's a young procedure. Actually in Israel it was neglected for a long time. I was the first in my country to make this kind of surgery and to make a lot of kind. I have several courses for also surgeons, and it's nowadays I can see more and more surgeons that use this kind of treatment modality. In sometimes that we can, if you remember my cases, in some cases it was the only modality and the fastest modality and the cheaper modality to treat this kind of patients. And in some cases it was combined with bone grafts, but in my eyes, in my opinion, it can be considered as a safe and predictable modality, and it can improve the quality of the life of those kind of patients that they didn't have a long time teeth or lose all the bone of the jaws. The patients all the time call and thank me for the quality of life after this kind of surgery. Thank you. I'm ready for questions.
All right. Thank you very much, Dr. Kablan. It was a very interesting lecture, and I'm sure we learned a lot. So thank you. It was a pleasure having you. And now we will start with some questions that we have from the audience. I will start reading them, but in the meantime, if you have more questions, please leave them on the questions box. We have a question here from Dr. Natesh from India, and he asks, how do you use the elastic tube to protect the nerve?
Okay, I usually use, the elastic tube of the anesthesia room. They have this kind of tube, and I take one, I cut it, at the length of the nerve, I open at one side at along the one side of the tube. I open it with and twist it over the T2. I twist on the posterior coverage of the nerve. It's very easy to do it. And once you do it, you forget about your nerve. You don't afraid from suction. You don't need any assistant to pull all the time the nerve or to let it's very it's very nervous when you see your assistant pull the nerve and talk with some one else. So when I use the tubing, it's very easy to insert it. I will know that I can suction the area, because some surgeons, we have a lot of blood because I touch the inferior alveolar artery and vein, because they come together with the nerve, Okay.
Right. Okay. Excellent. And we have another question from Dr. Deepak Sharma asking any complications from calvarial bone graft harvesting, and how difficult it is to perform.
Actually, this kind of surgeries, we have at the calvarian bone, we have two layers of bone. It's called diploid. We have the outer layer, we have inside, like a sandwich, we have inside the cancellous bone, and we have the entire layer. For big surgeries, we can use the entire thickness. The neurosurgeon help us to take the entire thickness. The neurosurgeon can not work over the dura, but in our surgeries we use just the outer cortex. We usually use CT scan before to know the thickness of the outer layer, the thickness of the cancellous layer, so we can make it so slowly, and it's work very nice. Inside the surgery, when I go to the operation room, I call the neurosurgeon. I told him I go to the operation room to take bone from the calvaria. If I have some complication, what kind of complication? If I let my colleagues that make residency to help me, because I have to learn how to do this surgery. Sometimes he can go inside a little bit inside the brain. So in this kind of surgery, when I see dura tear, it's called, and I will see the CSF leakage from the brain, I call the neurosurgeon. He will know very well how to treat this kind of small perforation. But actually, I have never ever called the neurosurgeon, because it's very safe. It's considered safe operation. Okay. And if I have some, I read other literature, or if we have more complication cases like fracture of the fascial bone and the calvarian bone, if you have the dura tear and you have CSF leakage, you can have meningitis or infections of the brain, but not in those cases. Okay.
Okay. Thank you. Very interesting. And we have another question here from Dr. Varun, asking you to mention, please, the technique to fix allograft and implant and residual ridge.
To fix what?
I think you mentioned to fix a graft. Yeah, well, to fix implant and residual ridge.
Okay. What I do actually, I mark my implant's location at the residual bone of the patient. I put the block over the residual ridge at the outer side. Let's say this is the block, and at this edge I make a mark where the my drill was at the crest, and I make the implant preparation at the residual ridge. I make the whole implant with the whole drills. If I want to make the yellow or the green drill, I make the entire preparation inside the residual bone. After that, I make the entire preparation at the bone block, and I make over, I make over drilling because I didn't want to fracture the block. But actually, the calvarian bone is so strong. I have never fracture bone during the insertion of the implant. But if you use the retromoral area, the ramus area, the bone is so sensitive and you can break it. So first I make preparation inside the residual bone of the ridge. I make preparation at the same location at the block, and I began to fix the implant. In order not to have rotation of the implant, I put some instrument inside. If I want to make 2 implants, I began to insert the first implant, and I put some instrument inside the second hole in order not to have rotation of the block during the insertion of the implant. Okay. Once you have 1 implant inside, the second implant is easy to fix, to insert through the block and through the residual bone. Okay.
All right. Thank you, doctor. And we're still receiving some questions, but I also would like to read some greetings. People are saying thank you, great lecture. Thank you for your lecture, Dr. Kablan. So we are very happy that you are enjoying the lecture, and it's really interesting, and it's an honor to have you here. So let me see. We have some more questions in here. Okay, so what is the role of the fat tissue?
What the reason for using fat tissue?
Yeah.
Actually, what I said during the lecture, that when we have a severe atrophy of the jaws, either the upper jaw or the lower jaw, it's always combined with the atrophy of the soft tissue. So if you want to make a good surgery, you can make at the first stage soft tissue augmentation. Before the bone augmentation, you have to improve your soft tissue quality and thickness. So some surgeons make soft tissue augmentation before the bone augmentation. They usually use the palate. And some surgeons use soft tissue augmentation during the surgery, the bone augmentation surgery or the implant surgery. Actually, I like the free fat tissue graft for many reasons, because it's a very fast surgery. During 2 minutes, you can have a lot of fat tissue, about 6 centimeters. If I want to take 6 centimeters from the palate to augment the ridge, I will remove all the palate, the entire palate. So if I take out from one side 6 centimeters of fat tissue, I can have from the opposite side again 6 centimeters. So I like the volume of the fat tissue that I can get. So I have a very nice volume to augment. The fat tissue know to heal very well, even if I leave it a little bit exposed to the oral cavity. I like it because it's soft, and when I go with my needle during the suturing, like we make soft lining of a denture. The fat tissue makes soft lining, act as a soft liner for the flap, and tomorrow the patient will have some swelling at the area of the operation, I know that I have soft liner for the original flap and the suture will not open. So actually, it's very easy surgery. I have a lot of tissue and the fibrosis healing of the fat tissue. You can read my articles about the fibrotic nature of healing of the fat tissue graft. You can also read about the aesthetic or cosmetic surgeons literature that they use the fat tissue, a lot of fat tissue to augment different sites along the body. The fat tissue can heal with fibrosis, and fibrosis, it's stronger than keratinized tissue because keratinized tissue has cells inside. If you look at the histology at fat tissue, you will see scar tissue. There is no cells, and scar tissue will survive a long time. Okay.
Okay, all right. Thank you for answering that. And we do have some one more question from Dr. Varun asking, how do you manage post-op neurosensory problems after the surgery?
You know, first of all, you don't have to panic as a doctor because there is a natural healing process. At the first week, let's say 2 weeks, the patient will feel fantastic because she had already anesthesia, prolonged anesthesia, like that you go with him home and you give him all the time local anesthesia. So he or she will not feel pain at all after this kind of surgery because actually they have continuous anesthesia at the site. But you have to all the time to explain the patient that I know, as a doctor, I know that he didn't feel the lips and the chin, but he will have a gradual solution of this situation all the time. After the first visiting after surgery, I make a chart and mapping of the anesthesia or paresthesia and follow after this chart. Every time I make a new chart and I compare. And usually after several weeks, most of the patient will have slight paresthesia and it will come over. Actually, you have to inform your patient before the surgery that he will have this kind of sensation. You have to give him a mental block. And we know how to I do this surgery more than 10 years. I never ever had to repair the nerve because all the surgeries went very well. But actually, we explain if you touch the patient and make him a surgery, you have to know how to correct the complications. So in cases that we have complications with the nerve, again, not at those kind of surgeries, but with trauma patient or oncological patients, we know how to correct, to fix the nerve. We know all the surgical approaches and tools to correct the nerve. But I told the patients that if you have a problem, we know how to correct it. But actually, we didn't have like many articles at the literature that they said that the paresthesia or light paresthesia, the patients know very well how to live with this kind of sensation because sometimes the small residual sensory sensation disturbance. The patient, even when I meet my patients outside the hospital, I talk to them and I want to hear that I have something wrong here. And in some patient, I ask him, "You have some?" No, I remember that sometimes I have here something wrong, but I eat, I laugh, I don't have problems with eating or speaking. But actually, at the majority of the surgeries, during the follow-up, that you can see that sensation improve week after week, and it usually proceed maybe half a year, 3 months, 9 months. Okay.
Okay, I think the topic of complications is very interesting, so maybe we will have to do a lecture about that, so you can, you know, further elaborate on this, because it's a very interesting topic, and certainly you can talk about this for much longer time. So we do have another question here. It says, "Hello, doctor. I am Dr. Yanam from India." So the question, it's a double question, okay? So it says, are there any cases where the nerve is sandwiched between soft tissue and buccal bone? And in that scenario, when the patient sleeps on the lateralization side, will there be any temporary numbness after he wakes?
Actually, in my surgeries, all the time I like to protect the nerve. What I mean, I put the nerve back inside the bone window, and I put all the time some allograft over the nerve, between the nerve and the soft tissue, because I know that the nerve can, if I give him the ideal conditions, like a bone allograft or bone graft around the nerve, he can build or rebuild a new canal. I never ever left the nerve directly under the soft tissue. I know that my colleagues do it, and they say that everything is okay with that. Actually, I believe at the regeneration capacity of the nerve, so all the time I put the nerve inside the bone, partially inside the bone. I protect with bone. I usually use allograft and membrane. So I didn't have this kind of complain about when I sleep at the right side. I woke up in the morning and feel this kind of sensation, because I know with my approach that the nerve already began to rebuild its new canal. Okay. But actually, I didn't like to leave the nerve directly under the soft tissue, because the soft tissue can heal with fibrosis, and the fibrosis can actually contact the nerve, and it can make some kind of disturbance in the nerve function, and it can make some kind of neuroma around the nerve. I know that the nerve like to be inside the bone. I put it back inside the bone, and I cover it with bone. So this is what I do. Okay.
Okay. And it's very clear, and I will just read some more messages of appreciation. So very nice presentation cases, highly experienced surgeon, Dr. Kablan. Thank you to organizers for a beautiful lecture from a renowned professor. So I think it's a very beautiful message to close this session. And thank you.
Thank you, everybody.
We will be more than happy.
I hope to meet you.
Thank you, doctor, and we're more than happy to host you again.
Thank you. Thank you. Good night.
All right.
Bye-bye.
Good night, and we will keep in touch, everyone. So keep in touch with us. Stay tuned for coming lectures.
On the screen, you can touch me anytime, if you need some consultation. Okay. Thank you.
All right. Thank you, doctor. Thank you, everyone. Good night.
Good night.